Okay. Hi, my name is Abraham Moscoso, and we're going to talk about immunotherapy in renal cell carcinoma. First, we will see a video.
Sunitinib is a standard first-line treatment for kidney cancer, but it's becoming decreasingly used in the first line. For these intermediate and high-risk patients right now, it's probably not the standard of care. The standard of care at Columbia and at other places, actually especially academic places, is combination immunotherapy with anti-PD-1 and anti-CTLA-4. So whether you'd get the same result with modern immunotherapy or not is a very good question, actually. The other thing is I can tell you that there have been preclinical studies and now clinical studies suggesting that you should give immunotherapy before surgery. There was a recent paper in the New England Journal of Medicine from the Hopkins Group showing that in lung cancer, giving immunotherapy before surgery is much more efficacious than giving it after surgery. We don't know whether that's the case in kidney cancer or not, but we do know that sunitinib in the adjuvant setting after surgery has generally not been helpful, actually. So the question is, if we gave immunotherapy before surgery and compared that to immunotherapy alone, what would be the readout? That is being tested to some degree in an ECOG trial at this point with nivolumab monotherapy. But it is an important question. Again, the two things are, if it was a different drug, if it was real immunotherapy, or if it was neoadjuvant treatment was applied, would yes, still have the same result.
So the definition, renal cell carcinoma, RCC, is the most prevalent malignancy within the kidney and the incidence is rising. Due to improved radiological evaluation, over 1,500 of the renal cancers are found incidentally. Renal cell carcinoma, RCC, is the most common renal tumor. The third malignancy within urological oncology and compromises 2 or 3% of all malignancies. RCC occurs twice as often in men compared to women. We will see a video.
I think it's a truly exciting time. I mean, bladder cancer has been pretty much neglected for decades. We only had cytotoxic chemotherapy that had some modest efficacy, I would say, in patients, and now we are witnessing a true revolution with the approval of 5 immunotherapies. We are still, I think, working our way through in how to best identify patients who may benefit from these therapies and how to improve these therapies. But I think we are witnessing very durable responses in a subset of patients who can benefit from these therapies for years with really sometimes minimal side effects. I think this is truly gratifying for any medical oncologist. So kidney cancer has always been kind of like a immune responsive tumor. It's really the only other cancer where we have essentially old-fashioned immunotherapy a la high-dose interleukin-2, similar to what we use in melanoma, approved with long-term benefits. So since November 2015, we have nivolumab approved, a PD-1 inhibitor, and we do know that we can induce very durable responses in a small subset of patients, around 21% of patients. However, simply speaking, it's not enough. And I think the future is going to be to look at combination therapies. This will come forward in the short term, I would say, in 2 different flavors. One is the combination with VEGF inhibitors, and the other one in combination with another immune checkpoint inhibitor called CTLA-4 inhibitor, or Yervoy. And I think we will witness in a very short amount of time how the first-line therapy for kidney cancer is going to be transformed. It's going to be driven by immunotherapy, truly.
Applications in medicine. RCC is one of the few tumors where spontaneous progression of metastatic disease after tumor nephrectomy has been documented. Therefore, much attention has been focused on immunotherapeutic modalities for the treatment of RCC. We will see another video.
The combination in immunotherapy are focused on the first line, and clearly it's the future. It's already the standard treatment with double IO, IO TKI. But the main point, we have two challenges. First, we have to know how to select the good combination for the good treatment for the good patient. And we have IO or IO TKI, and we don't really know. We need biomarkers to identify a patient who will derive any benefit from this combination. And in order to identify this kind of biomarker, we launched in France a randomized phase 2 trial called Bionic, and we select patients based on molecular groups defined on frozen tumor samples, and based on these molecular groups we allocated treatment double IO nivolumab ipilimumab or nivolumab alone or TKI alone. And with this kind of approach, I think we are going to find some biomarkers of response, and the trial is closed, the inclusion of the trial are closed, and so we plan to show the first result, I think, at the end of the year at the ESMO Congress, and we will see if we can try to find the good biomarkers to respond to this treatment, because we have a challenge on toxicity concern, of course, and we need this kind of biomarker-driven trial.
Pros and cons. Immunotherapy constitutes an interesting alternative to the established forms of treatment, and indeed, cytokine-based therapies have been used for many years, leading to favorable clinical responses in a small subset of patients. Cons. In many cases, as exemplified above, the immune system of patients is able to recognize and kill the autologous or HLA-matched tumor cells specifically, at least in vitro. These cells, the T cells, are finally unable to eliminate in vivo the tumors that they infiltrate, and more generally, which inhibitory mechanisms are involved in renal cancer, as well as these other tumors, is the objective of the intensive investigations. That we will see a last video.
So there's a lot of excitement right now in the field of kidney cancer about early adoption of immunotherapy with combination regimens that are built on PD-1 blockade. So we've seen last year the approval of PD-1 and CTLA-4 combinations with ipilimumab and nivolumab for patients with intermediate and poor risk kidney cancer. We're seeing a lot of exciting data, including at this meeting, looking at PD-1 plus VEGF combinations, the most recent being Keynote 426, which looked at exitinib and pembrolizumab in our patients with kidney cancer. But little was known about single agent PD-1, particularly with pembrolizumab in kidney cancer in untreated patients. So the Keynote 427 trial was a way of trying to get some data, information on how does single agent therapy perform in untreated patients. And it turns out it performs better than we thought. I mean, we were interested in exploring this, but when we looked at this Keynote 427 study, there were two groups of patients. Cohort A, which we looked at last year, which clear cell kidney cancer. Response rate there was 36%, better than we expected, with very good tolerability. This year, we're looking at the non-clear cell group of patients which have, these are patients with few treatment options. There are no FDA-approved regimens just for those patients. They often get referred for clinical trials, and in immunotherapy, they're often excluded from those trials. So we did a trial here just for those patients. Looking at 165 people, response rate was 25%. Once again, better than we expected. Most of the patients had papillary kidney cancer, where the response rate was 25%. We enrolled some patients with chromophobe cancer, where the response rate was less. Unclassified kidney cancer response rate was higher, but in general, a well-tolerated regimen, and then we looked at potential predictive markers of benefit in this group. And if you had PD-L1 expression on your tumor, which was over 2/3 of the patients, those patients had 3 times more of a chance of response than those that were PD-L1 negative. So the difference between a 10% response rate in PD-L1 negative and a 30% response rate in PD-L1 positive. So that sort of suggests that maybe we can do better at selecting the patients with non-clear cell kidney cancer. But this looks like is a potentially promising treatment that can be built on in the future for these patients who have so few options.
Conclusion: for the future, there are multiple avenues for continued preclinical clinical investigation with an antigenic and agents, novel chemotherapeutic agents with new molecular defined targets, and gene transfer approaches. Thank you so much.